Welcome to the House Health Committee. I'm Representative Erin Paré. I'm your chair today. Thank you for being here. Looks like we have a packed room, which is good to see all the involvement today on the bills that we have before us in committee. I wanted to first introduce our Sergeant at Arms. Thank you, Sergeant at Arms, for taking care of us today. Terry McGraw, Nina Lage, Bill Riley, and B.H. Powell. Thank you again for your service to us today. Also wanted to introduce our pages. If you could please stand when we call your name. I have Layla Brown, the Office of Speaker Tim Moore, Selena Guerrero Jimenez, Speaker Tim Moore, Dennis Pagoda Valdez, Speaker Tim Moore, and Jason Ventura Cruz, also the Office of Speaker Tim Moore. Thank you for being here today, and thank you for the work that you're doing here. I hope you enjoy yourself and learn something. Thank you very much. Representative Paré. Before we begin, Chair Donna White is recognized for a point of personal privilege.
As we introduced our Sergeant at Arms today, and we always speak about how important they are to us, I would like for us to have a moment of silence in honor of Bill Moore, one of our Sergeant at Arms, and he passed Sunday night with a cancer and a stroke, and none of us even knew that he was sick because he just continued to move forward. So I just thought if we could have a moment of silence for him.
Yes, let's recognize Mr. Moore with a moment of silence, please. Thank you very much for that. Okay, the House Bill 745 has been pulled from the agenda today, so our first bill that we're going to hear, there's a PCS without objection. Representative Chesser, this is the House Bill 798, NC Accountability Safety Net Safety Net Bill, and Representative Chesser moves that the PCS for House Bill 798 be placed before the committee for discussion purposes. Representative Chesser, you are recognized.
Thank you, Madam Chair. This bill, the PCS just brings it into alignment. There's a companion bill in the Senate, and so we just wanted to make some language changes to make sure both bills matched exactly moving forward. And so the bill itself is divided into two parts. The first part identifies non-governmental agencies that are under contract with state agencies, and essentially says that you cannot hold the non-governmental agency responsible for the actions of the state, and you cannot hold the state responsible for the actions of the non-governmental agency. It just puts a little firewall there. And then this second portion puts a safety net in place for the non-governmental agencies that says as long as they're acting in good faith under the bounds of their contract with the state agency, then they are indemnified to the same degree that the state agency itself is.
Are there any questions from our chairs? Seeing none, are there any questions from members of the committee? Motion. Seeing none, Representative Potts moves for a favorable report to the PCS for House Bill 798, unfavorable to the original bill with a serial referral to Judiciary 1. All in favor will say aye. Aye. All opposed? The motion passes. Thank you, Representative Chesser. Okay, next up, the bill before us today, second bill up is House Bill 747, no work requirement exemption FNS benefits. This is a PCS without objection. Representative Baker moves that the PCS for House Bill 747 be placed before the committee for discussion purposes. Representative Chair Baker, you are recognized.
Thank you, Madam Chair, and thank you, members of the committee. So the bill before you is a bill to help North Carolinians who are receiving FNS or SNAP, food and nutrition services, to help those North Carolinians get connected to work. So as you guys know, that's a federal law requirement that if you receive SNAP benefits that you must work. And actually the USDA website explains this, and they say, while SNAP is intended to ensure that no one, and these are their words, in our land of plenty should fear going hungry, its rules also reflect the importance of work and responsibility. So the way SNAP is set out by federal regulations is it has work requirements. And so we're going to just focus on the general work requirement. That's what this bill addresses. So in the general work requirement, able-bodied adults less than age 60 need to register for work and participate in SNAP, the employment and training if they're assigned. Okay, so able-bodied adults less than age 60, the general work requirement, federal requirement, is for them to do this. Now, there are a number of exemptions to that. And those exemptions, if you look at the bill, are basically outlined under Section C, all these different exemptions. This bill does not change that at all. This bill does not touch that. What this bill is doing is trying to get our state to do what we need to for these people, because the way the federal law is set out, there are two parts to it. Number one, the person registers. Number two, the state assigns them, but our state currently doesn't assign them to employment and training. They leave that as a volunteer opportunity. So basically we're saying, you know, gosh, we want to help you. We want to help you get to work, but you just have to come let us know and volunteer, and we're not assigning you to employment and training. We're not connecting you with a network. So what this bill does is it encumbers the state to do what the federal government has told us to do. The federal government says that people in this category must register, and that the state needs to assign them so they can get employment and training, so they can get connected with a network. But in North Carolina, in operationalizing that, we have left it to be voluntary, which leaves people not, kind of not knowing where to go next. So again, the federal government gives the states authority to operationalize it, and registration doesn't equal participation. So in North Carolina, our work requirement is voluntary, and so it's like a suggestion. So again, what I'm saying is our state needs to do what they need to do to empower people to be able to meet this federal requirement. So that's really all the bill does. It says that we as a state are going to do our part to empower people in this journey. And I have worked extensively with DHHS and really appreciate, I know the secretary is a strong supporter of the empowerment and the self-sufficiency that comes when people work. So I know they're behind this concept. They want to do this. There will be this is new for us. So right now we're not doing it. And so people, again, because people volunteer, we're not actually doing this across the state in a way that would help our citizens. So we'll try and smooth out, how can we do this? What you should know is that if somebody is assigned, as per the federal statute, and we don't have the ability to link them, we as a state haven't gotten that up and running, that's another exemption. That person, that citizen, is not going to be held responsible. It's our job as a state. So this does not encumber people. It actually is helping them, because, how dare we say, yeah, we want you to work, but, good luck, come let us know, instead of saying, well, here's what you could do. Here are the facilities, here are the businesses, here are the training programs, here's what already exists in our state, here's what exists in your county. That's what we're trying to do here. But so we're going to work together to get that up and running, for the benefit of our citizens. And again, you all know how important productivity is in terms of mental health, knowing that you have a purpose, and we want to help enable people with that. So appreciate your consideration. We will be continuing to work with DHHS to see how we do this. Again, no exemptions are changed. Nothing else has changed. We're just trying to have us as a state step up the way we feel like we should. But appreciate your consideration, and the process is a little complicated, so I'm happy to answer any questions.
Thank you, Chairwoman Baker. Wanted to take a moment to ask if any of our chairs have questions or comments. Okay, seeing none, are there any questions or comments from the committee? Representative Ball, you are recognized.
Thank you, Madam Chair. Thank you so much, Representative, for continuing to work with DHS. I do have a question. You may not know, but perhaps someone else does. Is it the plan for this to move to rules and to the floor today?
I do not know that answer.
The reason follow up.
You are recognized for follow-up, Representative Ball.
The reason I asked that, I'm wondering if there would be an opportunity for you to work with DHS and smooth these things out. Is it your intention to do that before we vote or after the bill is passed and moves on?
I think I know my intention is to go ahead and do that after we vote. I will say DHHS and I have already been working together, and the PCS reflects that. They've put some language in here that they feel like, puts it in a good position to go forward. I don't want to speak for them, but that's certainly what we've been doing in good faith.
Thank you.
Are there any other comments or questions? Representative Brockman.
I have a quick question. What if, will we also help with transportation if they volunteer and they can't make it to a location? Is that the intent?
Chair, you're recognized.
So again, the intent of this bill is assignment, so that actually assigning them to the businesses and or industries that will help them. Transportation is not part of the bill. It's not negated, but that's beyond the scope of the bill.
Follow up.
Representative Brockman, you are recognized for a follow-up.
Have we thought about a transportation issue if they can't make it to the location?
I'm probably going to defer your question to staff. Again, this is about, qualifying for SNAP benefits and connecting people to work. So, sort of the broader program of SNAP and what that would entail is probably best directed to staff.
Can I rephrase my question?
Representative Brockman, you are recognized for one additional follow-up.
I guess I just worry that if they can't make it to the location, that their benefits would be taken away, and I guess that's the question that I'm really trying to get at the heart of.
Right, and there's nothing in this bill that would do that whatsoever. Again, yes. Unfortunately, right now, so many of our citizens aren't even being assigned, and they're not being offered, identifying opportunities, and certainly that's not a disqualifier for continuing their benefits.
Okay, just thank you.
Chairman Baker, would you still like to recognize staff for a response?
No, thank you so much.
Okay, thank you. Additional questions from the committee. We have Representative Belk. Did you have a committee or a question?
I did. Thank you.
You are recognized.
Madam Chair. In the bill, and I don't know if the PCS changed this because I haven't seen it, but it said that DHHS could not ask for any waivers from this program. Is that still in there?
So I think, Representative Belk, you're probably referring to Section 1, Subset A, and that is actually language existing, already pre-existing. It doesn't change.
So what was happening
Representative Belk, you are recognized for follow-up.
Thank you, Madam Chair. So when they were doing waivers, when DHHS was doing waivers for folks, was that because they weren't assigned and there wasn't an opportunity for them to be assigned? Why would they have asked for waivers?
Okay, and I will, again, staff's going to be more expert on this, but again, if I'm understanding your question, so the section about waivers talks about waivers to time limits established by federal law for FNS benefits for able-bodied adults without dependents. That is a subset. That is the part 2, and we're not changing that at all. That has to do with federal law set out for able-bodied adults without dependent children who are of ages 18 to 49, and that was affected by we can get too detailed, that was affected by the public health emergency, and we're not touching that at all. And so again, all of that is under federal law, not at all touched by this bill.
All right. Thank you, Madam Chair.
Representative Baker, did you have a question for staff? Wanted to
Oh,
recognize staff or no?
Thank you, Madam Chair. I think I'm fine. Thank
Okay,
you.
thank you. Representative Cunningham, you are recognized for a question.
Thank you, Madam Chair. Representative Baker, the training is some type of training that's mandated. How is that going to be addressed?
Right, and that's a great question. Thank you, Representative Cunningham. And so again, this is operationalized by the state, so the state can do it in any number of ways. And there is a definition around employment and training, federally, but what states will do, some people connect them to unemployment opportunities that already exist online. Some people connect them with businesses that do that kind of training, whether it's the Salvation Army that, incorporates them into what they're doing and their orientation. So it's quite broad, and I think that's what's exciting is that we in North Carolina, working with DHHS, who also knows the county connections, the counties are empowered. So the state, we as a state need to assign people, and then those counties know what they have as best resources, and they can either connect to what they have, or if we see in the state, this is a good access portal, we can use that. So it's quite broad what we could do.
Follow up, Madam Chair.
Representative Cunningham, you're recognized for a follow-up.
Thank you. Do you know what the estimated cost is going to be to the Department of Health and Human Services for the mandated training?
Right, and so another good question, and we've looked at that, and they are trying to figure that out. So in this program, there are multiple steps. One is 100% federal match. One is a 50-50 federal and state match. And so that's what we're looking at, and the numbers have changed going back and forth. One thing that you should realize and that we are realizing as we talk about the numbers is that when you assign people, actually, so say 100% of the people that you would assign, if you're looking at that, only about 30% of them actually end up going through employment and training, because once you assign them, a lot of people find out about work options and go and do work, or go ahead and are able to make different decisions. And so across states, that's what has been seen. And so again, the cost would depend on what our people do when they get us once they are assigned. And so that is a number we're working on and trying to see, do we need more people at the state level? But so again, and that's why it's important to know the federal law says that the state can assign people, and if we find that we don't have the money to fill those slots, then those people stay on their benefits, and we continue to work at a state level and say, all right, well, what kind of money do we need to ask for going forward?
Madam Chair, I really didn't get the answer that I wanted, but that's fine. Thank you.
Thank you. Representative, okay. Moving on. Representative Humphrey, you had a question? You're recognized.
Thank you, Madam Chairman. I just want to make a statement regarding transportation. I thought that was a good point, but I know throughout rural North Carolina there are transit systems that could definitely partner with those in need of in need of transportation. So maybe that'll be something we can consider. I know they're federally funded, and I think there's some state funding there too. So it'd be a good little partnership. Thank you, Madam Chair.
Thank you. Are there any other questions or comments from the committee? Seeing none, Representative Lambeth moves for a favorable report to the PCS for House Bill 747, unfavorable to the original bill, with a serial referral to House rules. All in favor will say aye. Aye. All opposed? The motion passes.
Thank you, Madam Chair. Thank you, committee members, and look forward to continuing to work together. Thank you.
Okay, next bill up before us is House Bill 809. That's the Hospital Violence Protection Act. Okay, and that would be Representative Reeder and Representative Pirtle. There is a PCS on this bill, and without objection, Representative Reeder moves that the PCS for House Bill 809 be placed before the committee for discussion purposes. Representative Reeder, you are recognized.
Thank you, Madam Chair and members of the committee, and also thanks for my sponsors, for Representative Miller and Pirtle, who've helped me on this bill. I'm here to ask for your support for House Bill 809, the Hospital Violence Protection Act. This bill helps to address the growing problem of violence against healthcare personnel and hospital personnel. As you may not be aware, violence against healthcare workers is growing at a crisis level. When medical staffs are faced with this level of violence and disruption, it doesn't allow us to provide care to the patients who need our full attention. It also contributes to burnout and is also a contributor to the workforce shortages that we're facing across healthcare. According to OSHA, healthcare workers account for 71% of all non-fatal workplace violence-related illness and injuries. This makes healthcare workers the most dangerous occupation, believe it or not. This caring profession has more injuries than any other industry. Healthcare workers are 4 times more likely to experience violence at work compared to other industries. From a recent survey of my physician peers in emergency medicine, 66% suffered a verbal or physical assault in the prior year. Several years ago, the General Assembly increased the penalties for assault on a healthcare worker and emergency personnel. We know that these assaults happen on a daily basis across North Carolina. Unfortunately, over the last 4 years, there have only been on average 20 charges and 30 convictions for assault on a healthcare worker across the state. Violence occurs throughout the hospitals, but it disproportionately happens in the emergency department. This is resulting from staff shortages, mental health issues, lack of treatment facilities for mental health, ED boarding. This bill isn't a solution to the whole issue of violence in hospitals, but it begins to address some of those issues. And the bill asks for really a few things. First is that each hospital who has an emergency department develop and implement a security plan to address violence. Although there are some standards for hospitals related to safety, most of them relate to patient safety. It doesn't relate to the staff safety and violence towards the staff. Another part of the bill is to require at least one law enforcement to be present in the emergency department or on the campus at all times. This will help increase reporting of events, help with arrest, prosecution, and to protect our healthcare workers from violence. We've talked about the crisis of mental health, and that is an issue, but what we see in emergency departments all the time is not violence from patients who are suffering from mental illness. We see violence from families and staff and other people towards our staff from other people who are just visiting who are unhappy with what is going on. So a law enforcement officer at all times. We've had discussions with the Healthcare Association and about this requirement. The cost is a bit of an issue, but really the bigger issue is making sure that we have the availability. As you all know, that law enforcement officers are in short supply right now. So this does give an additional year for this implementation. Finally, we asked for a report back to the Oversight Committee about the charges, convictions, the incidents of violence in healthcare hospitals. And I would ask the committee for support of this important issue, and I'm here for any questions.
Thank you, Representative Reeder. Are there any questions or comments from the chairs?
Okay, I have one.
Chair Lambeth, you are recognized.
Representative Reeder, thank you for bringing this bill forward, and I agree with you. This is an issue that needs to be addressed, and I think you've approached it with your background in a reasonable way. I do have a couple questions. I wondered if the Joint Commission that accredits hospitals, do they not address this area at all of security?
Thank you. Sorry.
Representative Reeder, recognized to answer the question.
Thank you, Representative Lambeth. There are standards from Joint Commission, but most of those deal with safety of the patient, and they don't really get into address how do you protect the staff from violence, especially for non-patients. And so I think that that's why this bill is important.
Follow-up.
Follow-up?
Only other question I had was about the cost. It would seem that obviously all the big hospitals, even the mid-sized hospitals, they're going to have security. It's not an issue. And the ones I would worry about is the really small rural hospitals that are already struggling, and adding the cost of an officer 24 hours, 7 days a week could be an issue, particularly those off-hour shifts. And that's the way I read this bill. Is that a correct interpretation?
Yes, it is. One of the things that in working with stakeholders, is that we've created some language for hospitals that have done their assessment and don't feel like there needs to be an officer 24 hours a day. Let's say the police station might happen to be right across the street. If, when they've done that plan, that they can ask for an exception for that law enforcement officer from DHSS. I think that certainly hospitals are struggling with cost, but the cost of a law enforcement officer probably less than they're paying for a traveler nurse right now.
Representative Wheatley, you are recognized.
Thank you, Madam Chairman. Just a brief question. This doesn't include patients, right? It's just for outside visitors and families, that because patients often scratch, bite, do hit, be out of disorientation and because of their illness. So this doesn't include patients, right?
Representative Reeder, you're recognized to answer the question.
I believe that clinicians who are in this space can recognize when it's a demented 80-year-old who lashes out, and that's not going to be prosecuted. But every day in hospitals and emergency departments, we have patients who or family members who have their faculties, who strike, verbally, physically assault healthcare workers. And those people who do that, even if they are patients, that's not right. And we should be prosecuting. That's what the law says. So if someone is drunk and runs over someone, we have no problems prosecuting them for drunk driving and vehicular manslaughter. But somehow, because you're in a hospital gown and you're acting out, we feel that that's an okay thing. I think that I would rely on the clinical staff and the judicial system to help adjudicate whether that patient had the capacity with which to do that. But we know that our staff, physicians, nurses are being assaulted on a daily basis, and we've got to do something to prevent that.
Representative Liu, you are recognized for a question.
Thank you so much, Madam Chair. I have a quick question. I understand how important it is to protect the safety of our healthcare professionals. And do you think it will be helpful or it's necessary to install metal detectors in our emergency rooms and hospitals? And I have heard from our doctors and nurses, and one doctor especially, like she mentioned to me that she had to fight with a patient who carried a knife into the emergency room. And a police officer on site may not be able to stop that. But any comments from you would be very helpful. Thank you.
Representative Reeder, you're recognized.
I think best practices in emergency departments is to have metal detectors. When we've looked at studies, patients actually prefer that because they know that their safety is benefited from that. We can certainly come back next time and think about how we would do that and install metal detectors in hospitals. The challenge is for many hospitals, there's dozens and dozens of doors by which people can enter, and so it does become a bit problematic, but I think that that's a good point.
Okay, we have a few more questions from committee members. I just wanted to recognize the clock. We have a hard stop here about 10 minutes till, and we have one more bill to get to, just so the members of the committee are thinking about time. Representative Cunningham, you are recognized for a question.
Thank you, Madam Chair. Dr. Rita, and I probably said that wrong, Representative Rita. I'm a nurse, and I have been hit, and I have been bruised and all of that by a patient that was delirious, suicidal, and was trying to escape. But we did have in place security, but by the facility being so large, the person couldn't get there. If you got 10 floors, they can't get there fast enough to prevent it. So I know that things are in place in the larger facilities, but it sounds like it all sounds good, but the costs keep adding up with it. And so I'm trying to figure out where's all this money going to come from with us having shortages in every aspect of the workforce, not just healthcare, correctional officers, sheriffs, all of them. We have a shortage. And how are we going to do all of that to enforce something that some of the facilities already have in place? Now, I'm not saying they're experts in that area because law enforcement are supposed to be, but I don't see how putting one person in a facility is going to cover all that area and going to be such preventive in their actions.
Representative Reeder, you're recognized.
So the bill says that the hospital has to do a security assessment. And for some small hospitals, one might be enough. For our hospital, and I come from a big health system, our police force has 100 full-time officers, 50 part-time officers, making our hospital police the 10th biggest police force east of 95. This just says that you have to have one. What my hope and belief is that when they do the assessment, they will say, these are the things, steps, not just personnel, but other policies and procedures to ensure that our workers are safe. Again, 71% of the non-fatal injuries workplace are in healthcare workers. So the patients, the people who are taking care of us suffer injuries more than any other industry that's out there.
Thank you. Representative Blackwell, you had a question?
Just a quick comment, if I may. This is a good bill. Shines a light on an issue that we need to address, but I'd like to offer the suggestion, if I may, that it seems to me with the delayed effective date that there would be time, and I would hope that the Joint Health Oversight Committee could take a further look at this, the issues that Representative Lambeth raises about the small hospitals, the rural hospital, the issue that Representative Cunningham raises about, well, somebody's got them, but they're too far away on a big campus. And also whether we might be in a position to help some of the smaller hospitals even with grants or appropriation. I just think that's something we could do and maybe take some action on in the short session.
Representative Reeder, do you have a comment?
No, I appreciate that comment. What I would hope and ask the committee to do is to pass this forward. We continue to work with stakeholders to figure out how best to get this implemented.
Thank you. Any other questions from the committee? Seeing none, Representative Pirtle moves for a favorable report to the PCS for House Bill 809, unfavorable to the original bill with a serial referral to House rules. All those in favor will say aye. Aye. All those opposed? The motion passes.
Thank you very much.
Okay, we're on to our final bill. While we get situated for the next bill, House Bill 808, which is the Youth Health Protection Act. I wanted to just recognize that I unfortunately didn't see the three names at the bottom of the sign-up sheet that were wanted to speak on House Bill 798. If you're still here in the room, I'd like to give you an opportunity right now if you'd like to walk up to the podium and say a few words. We'll probably limit it if there is one person opposed to the bill and one in favor of the bill, then we'll limit it to one on each side for 798. Okay, they're no longer here. So we will move now to our last bill, which is House Bill 808, Youth Health Protection Act. This is a PCS. And without objection, Representative Blackwell moves that the PCS for House Bill 808 be placed before the committee for discussion purposes, but I do believe you have an amendment, Representative Blackwell, correct?
That's correct.
Okay, would you like to take the amendment now?
Yes, please.
Okay. Representative Blackwell is recognized to send forward his amendment, and you are recognized.
Okay. There are a couple of things in this amendment that are primarily technical or sort of a restructuring. First of all, if you notice on page 2, there's a listing on lines 28 through 46 of things that are not included in the term surgical gender transition. There is a similar provision in the PCS that's over on page 3, but it's less extensive. So essentially we're deleting those items on page 2 and moving them all over to page 3 so that you will see there are now going to be 6 exceptions, if you will. The last one, item 6, is the most recent addition. I wanted to thank Dr. Reeder for his suggestion and input on that. The other thing that is added by the amendment is the section that starts at the bottom of the amendment that simply says that state funds will not be used for these surgical gender transition procedures that are not allowed with respect to minors. I would ask the committee's approval of the amendment.
Is there any discussion on the amendment? Move. Seeing none, Representative Lambeth moves to adopt the amendment. All those in favor will say aye. Aye. All those opposed? The amendment passes. Now on to the bill.
Thank you, Madam Chair. I want to start by talking a little bit about what the bill does and what it doesn't do. What we're dealing with here is limited to surgical procedures that are used for gender transitioning on minors, that is, people under the age of 18. This is not a bill that is about denying surgical procedures to those 18 and older who choose to have those types of procedures, but rather it's about just dealing with minors. Secondly, I would call to the attention of the committee, just by way of example, that under North Carolina law currently, if I understand correctly, and hopefully Ms. Boney can correct me if I misstate our discussion, if you are under the age of 18 in North Carolina, you cannot get a tattoo at all, even with your parents' consent. You can't get a body piercing other than for earrings without parent consent. But we allow these surgical procedures that in many instances maybe are irreversible and life-changing for children who have not arrived at 18 years of age. We're simply suggesting with this legislation that that's something, because of its significance, for its life significance, that it's a choice that should be made when the child is of age. And that's essentially all that we're trying to accomplish here. There are studies on both sides of many issues. There are studies here, for example, that suggest that a lot of children change their minds. There are studies that suggest complications. Many of European countries that started these procedures, I think maybe before we did, are changing their positions on these things and finding that these kinds of procedures should wait. And that's all I'm suggesting by this legislation. And I would like to ask if the chair might allow my colleagues who are co-sponsors, if any one of them might want to say something, to also speak on the bill.
Would any of the co-sponsors like to say something? Representative Fontenot, you are recognized.
My support of this bill is built on a very simple supposition. And that supposition is this: there is at least 2 examples in our nation's last 100 years of medical experimentation we began in the name of justice, equity, and the promise of a better life. In both of those examples, we have looked back and condemned the parties responsible. On my floor remarks on this bill, I will reveal more about this subject, but I hold that I believe we are doing the same thing now. We are not considering all the evidence to come to a conclusive decision on whether we are really helping the vulnerable or we're hurting the vulnerable. For instance, in an article by Jamie Reed, a woman who identifies as queer, who is married to a trans man who worked at a caseworker for Washington University St. Louis Trans Clinic for 5 years, she writes in support of what we are doing. Why? She says medically, almost never does gender dysphoria appear by itself. In almost 99% of the cases, it is accompanied with 5 or 6 comorbidities: depression, anxiety, PTSD, drug and alcohol abuse, lack of parental attachment, and obesity are just a few to name. Medically, what is the appropriate procedure that has been established in Europe is that before any surgery should take place because of its serious nature, each comorbidity must be ruled out. According to her, what is taking place is that there's a broad assumption because of the social contagion that the gender dysphoria is causing those comorbidities, and that on the other end, those comorbidities are not causing the gender dysphoria. We have discovered from those who have transitioned that that is not the case, or detransitioned. Most famously, Chris Beck, the Navy SEAL, recently detransitioned. What did he say? He said, I assumed my gender dysphoria was caused by I had all these issues, and therefore I transitioned to be a woman. He discovered that his issue was PTSD and depression, not his sexual identity. And therefore, he is even calling for more caution concerning these things. So this bill is not an attempt to hurt trans children. It is an attempt to protect vulnerable populations, what is clearly still experimental, to the point that England now is banning the use of puberty blockers and requiring a very extensive process before surgery is ever considered. What we are calling for is relatively simple: to not resort to irreversible procedures that are dangerous before we absolutely, positively, without a doubt know that they will actually help. Last week, I hope we saw in the news, a young man undergoing a vaginoplasty died because of E. coli from his own rectum that was used. Why? It's still experimental. That's why. Here we have a young man in his teens perishing at the hands of radical activism in the name of justice and equity, that we have done this before. This has happened in our country. And then we all look back and say, oh, I would have never done that myself. Why do we so often assume that the people in the past didn't make the same mistakes that we're making right now? I challenge everybody in this room to consider that fact, that in the light of the last 100 years, we have done this twice. If you want to know when that took place, tune into my floor remarks. You will find out. I hold that we should protect the vulnerable and help them to work out their issues. They should have extensive mental health coverage and counseling. They should eliminate every possible thing that can be causing this issue, and then they should have these services. I believe that'll happen when they're 18 years old.
Representative Fontenot, I hate to cut you off. We are actually past time already, and we have another committee meeting that is meeting in here in about 8 minutes, so we really need to call time. I do have a motion. Representative Potts moves for a favorable report to the PCS for House Bill 808 as amended, rolled into a new PCS, unfavorable to the original bill with a serial referral to House rules. All those in favor will say aye. Aye. All those opposed? No. The ayes have it. The motion passes. This committee is adjourned.